We are still waiting for Jordan, who is our moderator, but I'm going to go ahead and get started with a couple of housekeeping materials and this introduction. Across the United States, rural hospitals make up 35% of all healthcare facilities. In Nebraska, 68% of our hospitals are in rural areas. Nearly a quarter of all Medicaid recipients in the state of Nebraska rely on rural healthcare facilities. As a result, those facilities also rely on Medicaid funds to continue offering critical services to their communities. Rural healthcare facilities and the providers who staff them are among Nebraska's most important resources. Today, our panelists will discuss how we pay for healthcare in rural Nebraska, the role that Medicaid plays in that funding, and the impact funding has on providers and patients. With this webinar, OpenSky will provide some of the tools needed to understand this crucial infrastructure, as well as tips on how to effectively engage with your state senators to ensure all Nebraskans have access to quality care. Here's just a couple of little housekeeping items. We will be recording this webinar and it will be made available on OpenSky's YouTube. You can also reach out to our outreach and engagement manager, Noah Rhodes, and he would be happy to send it to you directly. If anyone has questions you would like to ask our panelists, please feel free to put them in the chat. The chat is private, so your questions will come directly to us, and we will make sure to get them in the Q&A following our panelist presentation. As a final note, there will be a survey sent out to everyone in this webinar. If you could fill that out when you receive it, that is incredibly helpful for us at OpenSky to make sure that we continue putting on events that are helpful to everyone in the future. I'll just go ahead and start introducing our panelists. I will introduce Jordan as soon as he hops on. Jordan will be ideally the one moderating today, but I am happy to start by introducing Allison Orris. Allison Orris is a senior fellow and director of Medicaid policy at the Center for Budget and Policy Priorities. Allison has more than two decades of experience in health policy, spanning work in the federal government as well as the nonprofit and private sectors. She specializes in Medicaid and other health programs with a focus on advancing state and federal policies to make coverage and healthcare services available and affordable for people with low incomes. Thanks so much for being here, Allison. We also have Jed Hansen. Jed Hansen is the Nebraska Rural Health Association's executive director and serves as the Nebraska Hospital Association's senior rural consultant. He practices in urgent care and emergency departments across Nebraska and leads projects focused on the rural emergency hospital model, improving veteran access to care, rural dental, mental health initiatives, and rural senior dignity projects. Hi, Jed. Thanks for being here. We have Tyler Sherman as well. Tyler Sherman is an advanced practice registered nurse at Webster County Community Hospital in Red Cloud, Nebraska. He's a Nebraska native and earned nursing and family nurse practitioner degrees from UNMC. Much of Tyler's clinical experience was gained in rural communities throughout the state, where he also pursued specialized training in rural trauma care. Hi, Tyler. Thanks for being with us today.
Thank you.
So I think we're just going to go ahead and keep moving because I know we have some folks on here that are probably on a tighter lunch schedule. So I'll just go ahead now that we've done introductions. We're going to talk for a couple minutes about kind of Nebraska in context. So Jed, I'd like to start with you, if you don't mind. Could you talk to us about some of the key challenges that exist for rural Nebraskans that are trying to access healthcare?
Yeah, thanks, Lily. That's a great question. Can you hear me okay? I'm getting a little reverb there. I have to take these out. Can you hear me okay still? Okay. So, challenges in rural Nebraska, there's some well-documented spaces. I mean, in general, our rural populations are going to have transportation challenges. There's going to be greater financial challenges than what we see in Omaha or Lincoln. And then you're going to have that confluence with chronic disease management as well that exacerbate a lot of those issues with access, with affordability, with transportation. Within the context of Medicaid, we disproportionately a higher percentage of rural Nebraskans do utilize Medicaid services or Medicaid to access their health care than what we see in Lincoln and Omaha. Greater than, or it's not greater than, about 50% of all Medicaid enrollees do live in rural Nebraska, compared to 30 to 35% of the population, depending on the metric that you're using. We also know that from a Medicaid standpoint, that roughly 40% of all pediatric care is utilized through Medicaid services in rural Nebraska, and approximately the same percentages for maternal care and for mental health. So Medicaid is a vital program for accessing care for our rural neighbors.
Thank you so much for that, Jed. I'm feeling a little reverb on my end too. Hopefully, um, you guys aren't hearing that now. So thank you so much for that background. I think that there's so much about Medicaid that, it's important for folks to understand and to understand how greatly it impacts our kind of outstate neighbors. So thank you so much for that background. Tyler, I'm going to hop to you now. So some of these challenges that Jed talked about, can you talk about how those challenges impact care in your position or what you've seen?
Yeah, from a small community, we're about 1,000 people. We have a high significance of Medicare and Medicaid people. I know we're talking about Medicaid, that being from a small town, you interact with your patients on a daily basis, inside and outside of the clinic and all that. So you do have those friendships, those personal bonds with them, that you want them to have the best healthcare that they can receive. And it would be unfortunate if Medicaid was defunded or anything. And it really just right on to Jed's with the continuity of care with their chronic care conditions. We would require, if they don't have that care, seeing it when they are required, they would be more likely to be seen in the ER when it's almost too late to interject with any interventions that could have been prevented with their health care.
Thank you so much for that. I think a good follow-up question to that might be as well. So you're talking about how if they can't have this preventative care, that they do have to end up going and receiving emergency care. And is that more expensive? Can you talk to us a little bit about the cost of that, if you have
Yeah,
any?
that would, yeah, definitely be more expensive. That would almost be like how in medical terms, like a tertiary intervention instead of a primary intervention. It's kind of already, the situation's already happened. Now we're kind of working on preventing any further decondition of their condition.
Awesome. Thank you for that, Tyler. Um, Allison, I am really excited to hear from you. If you could share a little bit and take your time, because I know that it's not necessarily a simple topic, but can you kind of give us a snapshot of how Medicaid reimbursement rates work, how they influence access to care, and those sorts of things? And take your time, because I know it's not an easy thing to explain.
Thank you, Lillian, and thank you for having me. I appreciate that caveat. I could do a whole 45 minutes just on that topic, and I will not. But I think, what is really hard when we talk about Medicaid, I, come from the federal DC national policy landscape, but we do a ton of work with states at the state level. And every state has differences and nuances in how they run their Medicaid programs. Obviously, Nebraska has different considerations than a state that is less rural. But the sort of fundamental compact that the federal government and states share with Medicaid is that Medicaid, the federal government matches state spending on Medicaid, and does so. Did you hear any of that? I just got an unmute message. Okay.
I heard up until just the very last few words.
Okay.
So you're good.
I must have touched my keyboard. Apologies. Medicaid, the federal government matches state spending on Medicaid at a set percentage, and then that in turn requires the state to meet certain standards, like cover mandatory populations, cover mandatory benefits that must be provided. The federal government will also match the costs of optional populations, optional benefits. One of the optional benefits we often talk about are home and community-based services. So services that help people live in the community rather than need to get care in an institution. So very much like Tyler was saying, it's less expensive to pay for somebody's preventive care than it is to pay for emergency or inpatient services. It's less expensive to pay for home and community-based services. So states and the federal government often have an incentive to expand coverage and expand services to keep people healthier and avert care. And one of the other standards that's in place between the federal government and the states is that states commit to assure that payment rates are sufficient to guarantee access to services for Medicaid enrollees that are sort of consistent with access for people in the state and in various geographic areas of the state, consistent with somebody getting Medicare or private coverage. Now, you all probably know that Medicaid traditionally pays at lower rates, and that is something that the federal government kind of works with states to make sure that rates are sufficient, but you could still argue that Medicaid providers, Medicaid heavy providers, are often losing money on their Medicaid services relative to the rates that they get for other people. But even to just sort of take a step back on the reimbursement, states can choose to deliver services either on a fee-for-service basis or through managed care. With fee-for-service, the state sets a reimbursement rate for particular services, and that's how much the providers get for delivering that services. Nebraska uses managed care, where the state contracts with managed care organizations, paying the managed care organization a capitated rate that's sort of set based on risk adjustment and all sorts of actuarial calculations. And then the managed care organization goes and negotiates with various providers. And they might decide to pay a provider in a rural area more than they do, a provider in a less rural area, just as a way to guarantee access and to help provide, continuity of care and help some of those, rural providers that may have lower utilization stay in business. One of the things that has historically been a feature of Medicaid is that states can find ways to pay what are known as supplemental payments to hospitals or to other types of providers to boost the standard Medicaid rate, to help keep the providers whole, to make sure that providers stay in communities. And according to various studies, there are a disproportionately high number of rural hospitals and providers at risk of closing in Nebraska relative to other states. So the sort of state interaction with, making sure that the state is paying sufficiently to keep providers in business has always been an important feature. As we've moved from fee-for-service to managed care, there has been a move from those quote unquote supplemental payments to what are now called directed payments, where some of those effectively supplemental payments are made through managed care organizations. Usually the state can't be too directive with a managed care organization. They just sort of set the capitated rate, the managed care organization goes and negotiates, and the state is kind of out of the business of doing one-off negotiations. But states do have the ability through what are known as directed payments, which is something that's been discussed a lot in Washington these days, to try to set minimum provider payment rates or to add sort of quality incentives, do things to drive quality value access. And just looking through what's been approved in Nebraska, I see that there are about $24 million of directed payments to an academic medical institution of a public university. You all probably know who that is. There's also a smaller directed payment to dental providers to, again, make sure that there is adequate Medicaid payment for dental providers. But all of the reimbursement discussion that I'm talking about sort of assumes this state-federal partnership where the state spends its money, generates money, sometimes through taxes on providers, sometimes through general revenue, and has that money available from the state budget to draw down the federal funding, and where the federal government is willing to match the costs. And as we talk today, we can get into more details about some of the threats at the national level now, where some of that federal funding could be at risk, which would shift costs to the state if the state wanted to maintain provider payments where they are today.
Thank you so much for that. I can feel my brain literally growing as you guys are speaking because I so appreciate all of this information. I think our attendees absolutely will too. One thing, Allison, and it may have been just in the couple words that you cut out there a little bit, I want to ask you, because I think that it's been a lot of in kind of the media and communications around Nebraska, is the FMAP. And what is this FMAP thing? And can you just provide a couple little sentences? And I know I didn't prep you for that question, but just for folks that might not know what that means.
That time I muted myself on purpose by mistake. So the FMAP stands for Federal Medical Assistance Percentage. The key, like, what does that mean in reality, is the Medicaid matching rate. So the FMAP is set by statute, by a sort of formula that looks at the per capita income in a state. So the basic FMAP is set at 50%. That is the floor. And that's something that Congress is talking about, whether the floor should be lowered for states that have a higher per capita income. That's not you guys. The maximum is about 73% in a state like Mississippi, that is a very poor state. Some of the other states have higher FMAPs, or sorry, territories have FMAPs set by statute. So there are some FMAPs that are a little bit higher just because of statutory provisions. But Nebraska's FMAP, and I've sort of lost my piece of paper, is found at 57%. So that means that the federal government is paying 50%, 57% and a half to be exact, of most Medicaid costs. Now, the tricky thing, and something that you may be reading about, is that there are higher FMAPs, matching rates, for certain services, like family planning is matched at 90%. But the thing that has been most in the news is the potential reduction of the matching rate for the Medicaid expansion. And that's definitely something that I hope we can talk a little bit more about. Because there are currently about 70,000 people in Nebraska who gained coverage due to the Affordable Care Act's Medicaid expansion. And when the Affordable Care Act was passed, it sort of struck a deal with states, which was to say, we're going to cover some people at certain income levels in the new marketplaces, but we're going to shift some folks' coverage, rather than paying for them with tax credits in the marketplace, and those tax credits are fully federally funded. We're going to cover people in Medicaid up to 138% of poverty, which is about $35,000 for a family of three, using the Medicaid system. But the federal government in the early years paid 100% of those costs of Medicaid expansion, now pays 90% of the costs. And the 90% is important because states have built their budgets around that 90% and have assumed that, whether, and that 90% is sort of different than what is the reimbursement rate that a state pays its providers. The 90% is about, if a state pays $100 for a Medicaid service, let's just say, then the federal government is paying $90 of that $100. And the proposals to reduce the matching rate for the Medicaid expansion would result in states having to make hard budget choices. Some states would have to drop their expansions based on provisions in their state laws. And just overall, kind of would be a rollback of a commitment that the federal government made to help provide coverage for lower income people.
Thank you so much. That's very helpful. I think we see that acronym a lot, FMAP, and it's so good to have kind of that explanation. So Jed, I saw you nodding your head, and Tyler, don't worry, you're on deck after this question to Jed. Jed, while Allison was speaking, you were nodding your head. I want to pose to you the question, what are some of the biggest funding challenges that rural healthcare facilities and providers in our state are facing right now, maybe based on kind of the context that Allison provided?
Yeah, and what wonderful context, Allison. Thanks for providing that. So when you think of funding and reimbursement for rural hospitals, for all hospitals really, it's a three-legged stool. You have Medicare, you have Medicaid, and you have private insurance. And when we are having these discussions around Medicaid right now and looking at potentially significant cuts to that program, you're essentially tilting the stool. You're going to shorten that leg, and eventually you don't have enough of a leg to stand up on. And that may be a particular service. I think probably the most vulnerable service that we have in rural Nebraska is around maternal care and birthing services. But if that tilts too much with too many services, what you're going to look at are going to be clinic and hospital closures. And Allison did a great job laying out the FMAP. She was talking about directed payments. And one of the challenges that we have in Nebraska right now is that we were one of the last states to fully utilize the directed payment system. Last year, we had LB 1087 that was led by the Hospital Association for a more expansive directed payment. And we are still working with CMS trying to secure that directed payment program in the state. And for Nebraska, that equals roughly $1 billion in additional Medicaid funding. And if talks go a certain way in DC, we could be at risk of losing that supplement or that directed payment. And that would have a significant outcome on where services were to go. There have been a lot of headlines as far as the total number or the projected cut with Medicaid. The number that has been thrown out there is about $890 billion over a 10-year period. Well, that is what the House used as their scaffolding to send over to the Senate. I don't anticipate that will be a number that we'll look at, but I am concerned that that even a 10 or a 15% reduction in Medicaid reimbursement would have an outsized effect on accessing services, both again from vulnerable service lines within a hospital or clinic, and then total care for hospitals. So we're engaged with our federal delegation. They're probably sick of hearing from us at this point on Medicaid, but we'll actually be back out there next week and talking to them about that, because this is so vitally important. And contextually, one of the interesting things where we're at now is that in previous years, we would be going out and we would talking about needing greater rates or improved rates for Medicaid. Historically, you're going to see roughly 90% on the dollar paid by Medicaid or reimbursed by Medicaid for a service. Varies by service, varies by region. And so we were just wanting to get whole, and now we're out here just trying to protect that 90%. And I'll go back to maternal care and why this is so vitally important. In a state like Nebraska, where roughly 40% of our maternal care is financed through Medicaid, it's a volume game. And we had 1,700 total births in critical access hospitals last year. So you're looking at 700 to 800 births that were depending on the community where those were by Medicaid. If you were to remove those, you're probably going to be left with maybe 10 critical access hospitals and a handful of rural regional hospitals that would be able to assume enough volume to be able to take care of those patients. And there'd be real risk that if 10 or 20 or 50% of those patients were no longer eligible for Medicaid based off of FMAP, based off of things like work requirements or FMAP adjustments or a significant reduction in Medicaid expansion. Those then go from a patient where you're getting a 90% reimbursement to a patient where you're getting zero reimbursement. And people are still going to have babies. And so we need to have that very frank discussion with the federal government that it's not just Medicaid patients that are going to lose these services, that it is all patients in all rural communities that will lose vital access to healthcare with significant cuts to the Medicaid program.
Wow, Jed, that really paints a picture about how critical these services are. So thank you so much for that. Tyler, I want to hop to you now. And I think that in your role, you probably are also able to illustrate, like specifically for the people in your community, how Medicaid impacts the care you're able to provide, and then how these policies actually play out on the ground. Do you feel comfortable kind of addressing that question?
Yeah. Yeah, kind of just to repeat like what Jed said too, like we as the rural health hospitals, we do rely on Medicaid reimbursements to kind of just keep the doors open. And if that funding dries up, the hospital and the clinics are going to dry up too, requiring the community members to travel a further distance to go to other hospitals and clinics. I think especially, I feel like healthcare is a cornerstone for the rural area. And if you want to have that community continue to thrive and grow, you need to have a healthcare system, you need to have a school system. And I think if one of those goes, the other's going to go with it. I had a patient the other couple weeks ago that has a bunch of comorbidities, and she's unable to, she's on Medicaid, unable to fund her, unable to fund her medications. So like I have to kind of figure out which medication she needs to have, and she can only afford 2 to 3 of the medications. So we kind of have to get a little creative with how we're going to treat that, whether if that's from the sample clause that we get from pharmaceutical reps, kind of just to hold us through. I know we're looking at other sources of income, whether that's with outpatient settings or with other um, services. But with COVID, we had a thriving outpatient service that kind of has dried up now because those outpatient providers were unable to come down to Red Cloud, and they haven't. They decided not to come to Red Cloud after COVID restrictions lifted. So it's kind of a hindrance to the community and to the patients that I provide care for.
Thank you for that. I think it's so important when we're talking about policy, and we at OpenSky certainly try to do this, but just to paint the real picture of what is going on the ground, because that is really, what can influence people and policy decisions. So thank you for that. I want to hop back to Allison. Allison, you kind of gave us a little bit of an introduction to this, but now that we're kind of in this kind of phase of this webinar where we're talking about how critical Medicaid is, can you talk to us a little bit about what federal funding changes kind of are on the docket, how they might impact this rural healthcare that we're talking about in either Nebraska or other states with rural communities?
Sure. And I think Jed made a lot of points that I really agree with. And I think, starting from the place that, there's been a lot of talk about this $880 billion cut. I think it's right that the House may find a way to advance legislation, starting with a policy markup next week that is maybe more in the range of $500 or $400 billion of cuts. That would still be the largest, single Medicaid cut that we've ever seen. And the challenge about the way that Congress will make changes, which goes a little bit to this, conversation we were having before, is they're not going to say you must cut rural, or they're not going to say you must cut children, or you must cut maternity. They're going to do things that either cut the matching rate, the FMAP, or that take coverage away from people and shift decisions to the state. So one of the reasons that it's so important to be getting, state lawmakers aware of what's going on in Washington is that they are going to be left holding the bag to make policy decisions whenever, whatever Congress may or may not do happens. So some of the changes that we have seen sort of in the mix have been very targeted at reducing funding for the Medicaid expansion or making it harder for people who are enrolled in the Medicaid expansion to stay enrolled. And just yesterday, Representative Bacon said, he would draw a red line at a $500 billion cut, which again, I would say is better than 800, but is still very, very large. And he said, that he would be very open to policies like work requirements, taking coverage away from people who don't meet work requirements, excluding non-citizens from eligibility, which I would say most non-citizens already are excluded from eligibility. So there are some, nuances and details that need to be worked out there, but Medicaid typically only pays for citizens and people with limited lawful statuses. And Representative Bacon also talked about requiring more frequent eligibility checks. So just to talk about some of those policies for a second, we've seen experience in Arkansas and Georgia that requiring people to report work as a condition of getting their health care results in people losing coverage, it doesn't necessarily result in more people finding work. And so to think about some of the points Tyler was making, you have somebody undergoing healthcare treatment. They don't report that they either worked or had an exemption for a work. They don't keep taking their diabetes medicine, and they become less healthy. So I think, the risk that a work requirement would lead to more uncompensated care for providers in rural communities who are already struggling with not having adequate reimbursement is a real risk. And if the work requirement was applied to the Medicaid expansion population, that's putting 72,000 people's healthcare at risk. Asking people to report their eligibility or to recertify their eligibility on a more frequent basis also risks people who are actually eligible losing coverage just because of paperwork burdens. So again, we don't think that there are major issues with people fraudulently getting Medicaid. People are supposed to be reporting their major changes in income eligibility today. There are ways that states can check data, but having somebody have to do paperwork twice a year to keep Medicaid would likely result in people losing coverage, increase uncompensated care. And again, the non-citizen issue is one that, there are limited exceptions for coverage of pregnant women and children who've been in the country for less than 5 years. But for the most part, there are, due to legislation going back 20 years now, there are pretty strict restrictions on immigrant coverage for people who are in the country legally. And really the only coverage that helps people who are undocumented is what's known as coverage for providers who provide emergency services, because providers have to basically care for anybody who comes to their door. And so if an undocumented immigrant seeks care for an emergency condition, the provider can get paid for that. It's not money that's going to a person, it's money that's going to a provider. So I would just, say that for all of the conversation in DC, whether it's reducing the matching rates for the expansion or possibly just the general matching rate, whether it's getting rid of some of those provider taxes that help the state generate funding for Medicaid, whether it's reducing state-directed payments, all of those proposals are shifting costs to states and will force states to make choices, which could lead to reductions in access, could reduce benefits, could reduce coverage, or just, I don't mean just, reducing provider rates will undermine the systems that we've been talking about today.
That was very thorough, very appreciated. Well, I have one more question prepped, and I'll pose it to you, Jed. So obviously we've talked about, how Medicaid, funds these facilities and those sorts of things. Are there other sources of revenue for care facilities, and how do those other sources of revenue kind of fit into this picture?
Yeah, Lily, I think that's a great question, and had alluded to it earlier with my analogy with a stool. But really, we have three significant sources of funding for any hospital or clinic, and those are going to be Medicaid, Medicare, and then private insurance. Yes, you do see a little bit of cash pay, but really, when we're talking about funding, that's what we're looking at. And for critical access hospitals, they are reimbursed slightly different than what you would get with a larger regional hospital like Norfolk or North Platte or Scottsbluff, or than our urban facilities. So critical access hospitals are reimbursed on a cost-based reimbursement, meaning that their percentage of Medicare patients that they see, that portion is shifted, and then the federal government provides reimbursement for those costs. And then they're left with that mix, that payer mix between private insurance and Medicaid. And for any hospital prior to this year, that mix of having a healthy mix of all three of those to look at profitability, sustainability, and then mission, then making sure that they're serving their community, all go into that. And back to that three-legged stool analogy, if any one of those gets out of balance, you can look at disruption of care in the community. And you'd think, well, okay, Medicaid, let's go in one direction and say that you have a large private payer. That's going to be great. And what you're allowed to do then is you're allowed to grow that whole stool up, or you're allowed to provide some extra propping. But when you talk about Medicaid, really those percentages can be both a function of the ability for that hospital to provide services out to their total community, and it's a function of just the community itself. And in areas of this state, like Schuyler in Colfax County, in Lexington, in Dawson County, in Creed and Saline County, where you have large ag facilities, what you also get is that migration of Mexican and Central American families. You get now some of the Eastern African countries that are coming in there. And those are young, vibrant communities. And so their economies just look a little bit different. And making sure that we have Medicaid coverage so that that community can continue to grow in a healthy way, both as a population and economically, are very important.
Absolutely. Thank you for answering that. We are to the moderated Q&A portion of this webinar. I So we have folks write in. I have a couple things, and I'll just direct them kind of broadly to any of you. And if anything strikes you that you'd like to share, please feel free to just jump in. The first question that we have is, what is the impact, and then in parentheses, financial or like personal, to someone who is on Medicaid, then gets kicked off, and then gets re-enrolled or gets back on Medicaid? Is there, Jed, Tyler, Allison, is there anything that you feel like you can share on that question?
Can you repeat that one more time for me, Lily? Apologize.
Absolutely. Yes. No, and it was kind of phrased in a different way. So I think, have you seen in your line of work somebody who is on Medicaid and then gets kicked off, or maybe is then no longer eligible and then gets back on Medicaid? How does that impact either like maybe this three-legged stool that you're talking about, like maybe the financial portion of it, or for this individual? And Tyler, you may be able to share that if you've maybe had patients that have gotten kicked off and then gotten back on.
I know
Yeah.
that there's like a waiting period, kind of, that they have to like re-enroll and all that. That just goes ahead and delays their care more. That we can kind of work with them in the meantime, whether that's with, I don't know, because just for rural area, you kind of want the best for your patients. So you kind of work with them as best as you can, knowing that they're trying to get back on Medicaid. But it's just another delay of their care from that. And if they do have a big issue, then it's kind of more of a cash thing as an uninsured patient.
Very good point.
Yeah.
Thank you.
And I would just add, we talk a lot about churning on and off, which is the sort of, if somebody's income goes up and then it goes down and then it goes up, they may lose eligibility and may choose not to enroll in, other coverage through the marketplace if it's not affordable to them. So any policy that makes it more likely that somebody is going to lose their coverage results in, potentially debt for the person, and then possibly debt for a provider who sees them. Currently, depending on why somebody loses coverage, if they lost due to a paperwork issue and they should have still been eligible, there's a provision in Medicaid called retroactive eligibility that gives the ability to pay providers in a 90-day period previous to, when the person applied, if they were eligible during that coverage period. So, in the case of a work requirement, let's just say if a work requirement became law, then the person who lost coverage because they weren't meeting a work requirement and reapplied if they had an illness might not be retroactively eligible because they wouldn't have been working. But in today's, world, there's, some ability to do lookbacks, but, that depends on everything working smoothly. And I guess I just, think the sort of economic impacts for people when they fall off are big as for providers.
Yeah, I would echo what both Allison and Tyler were saying, and I think that the challenge becomes as eligibility waxes and wanes with patients, and especially with those with chronic diseases, and I'm especially thinking of diabetic patients that are needing insulin. You can see improvements in health. You can see when they have eligibility and can have regular appointments that their health improves, and then when that's lost, you're trying to really stretch really scarce resources, and oftentimes that can be done in a very scary way where you'll take them off of a daily, maybe their insulin between a fast acting insulin and a long acting insulin, and they can only afford one, or maybe they're just electing to. Maybe they can do their insulin, but some of their other medications for blood pressure and cholesterol, maybe those go away, or a blood thinner, and you're playing roulette with their health based off of really many cases an arbitrary decision that's being made that's outside of their control. And so it's frustrating. It's frustrating on the provider side. The financial side of it, obviously it's there. It creates challenges. It creates additional resources that are needed to stay on top of that through case management, through back end accounting and administrative functions. But at the end of the day, that patient on or off Medicaid, or with or without coverage of whatever ilk it is, it comes down to just the health of that patient. And we know that has significant impacts on accessing appropriate care, appropriate medications when that is a dynamic situation for the patient.
Thank you to all three of you for that. We are coming up on this 12:45 time, and I want to make sure that we respect that with our panelists. I will just ask one more question, which is a question of mine, actually. What is one thing that you just wish more people knew that you talked to about Medicaid? Is there anything that comes to mind that you're thinking, if everyone understood this, my work would be so much easier?
Go ahead, Jed.
Yeah, I had made a comment earlier about when we change coverage for Medicaid and when we change that eligibility, we ultimately in our rural communities change access to care for everyone. And that's something that I really can't emphasize enough, that when you're having conversations with others, regardless of where politics are at, understanding the totality and the importance of Medicaid and of appropriate Medicaid coverage affects everyone. And when decisions are being made, it's important to understand that within the context of what policies are being affected.
Yeah, I would absolutely agree with that. The sort of integral nature of Medicaid to the whole healthcare infrastructure and ecosystem is key. I also think, especially in this moment when there's so much focus on attacks on the Medicaid expansion, I think that it's just important to remember that Medicaid eligibility before the Affordable Care Act was incredibly limited. That people who are childless adults, low wage workers, think of an Uber driver, somebody who is trying to, make ends meet for a family, there was no pathway for Medicaid eligibility for those people. And in Nebraska, before the Affordable Care Act lifted parent eligibility, if you were a parent over 63% of poverty, and I don't have the dollar conversion, but that's very low, you wouldn't qualify for Medicaid. So when we talk about, able-bodied people or some of these attacks on the Medicaid expansion make it seem like very high income people are getting Medicaid, but the reality is that, Medicaid eligibility pre-ACA was really limited, and Medicaid today covers, so many births. It's the largest payer of nursing homes. It covers those low income workers who don't have job-based insurance. It really is, as Jed is saying, a core part of our healthcare system that should be protected.
Very
Yeah,
well said as well. Tyler?
I think if people realize that they're just one catastrophic accident away from kind of losing all their income and being down on Medicaid, that they would rather be a little bit more proactive having that Medicaid already established when they actually need it versus kind of trying to be reactive once they kind of be in that position. I think they're closer to that level than they think.
Yep, I think you make a very good point. Well, thank you so much to all three of you. You were wonderful panelists. I know that we just it was just the tip of the iceberg what we talked about today. But really so appreciative for your time. And if there were questions that we didn't get to in the Q&A, attendees, feel free to email them to our team at OpenSky, and we're happy to direct them to Allison or Jed or Tyler after the fact. So please fill out that survey about the webinar and any topics you'd like to see covered. And thank you one more time to our panelists. You were wonderful.
Thanks for having me.
Absolutely.
Yeah.
Have a
Thanks,
great
Lily.
rest of your day.
Thank you.